Today I would like to talk about endocarditis. Endocarditis is infection of endocardium. Endocardium is the inner layer of the heart. Specifically, endocarditis is going to be affecting the valves of the heart. Epidemiology: when we suspect more endocarditis in a patient, when the patient is more than 60 years old. Back in the day, it used to be 30s. Why? Because the rheumatic fever used to be common before, but right now it's not as common as it used to be. When the patient is a male and the patient use drugs, intravenous drugs, why is that? Because the patient is creating a direct pathway for the bacteria to be introduced in the bloodstream. When the patient has a poor dentition, and also it's important to recognize that most of the time the valves affected are going to be in the left side of the heart, such as the aorta and also the mitral valve. Only 10% of the cases are going to be the affection are going to be in the right side, are going to be the pulmonic and the tricuspid valve, and 13% are going to be both side of the heart are going to be affected. Endocarditis, we have two types, infecting and non-infective. In non-infecting endocarditis, we have like a marantic and Lippmann-Sachs. Lippmann-Sachs are going to be in patients who has systemic lupus erythematosus, and marantic is going to be a patient with cancer. So infecting endocarditis, we can divide in acute, subacute. Subacute is week to months, acute is days, and culture negative. I'm gonna explain what I mean with that. So here we have in the right side of the heart, that is the most common, the aortic valve and the mitral valve. In the left side of the heart, the pulmonic valve and the tricuspid valve. That's gonna be only 10%. What is the most common microorganisms? Staphylococcus aureus is the most common. Especially it's gonna be is, are gonna Staphylococcus aureus affects especially normal heart valves and is the most common of healthcare associated infected endocarditis. Strep, such as virions, is gonna be most common and community acquired. As I mentioned, subacute are going to be more common caused by virions strep, Staphylococcus epidermidis that is the same as Staphylococcus aureus. What differentiates between those? Coagulase. Coagulase positive is going to be aureus and coagulase negative is going to be epidermidis. Gram-negative rods and candida. And culture negative, what does mean culture negative? When the patient has meets all the criteria or meets the clinical scenario for having infected endocarditis, but the cultures are negative. We are going to suspect they're in Hayes groups. Hayes group is a group of bacteria that are not going to be culturable, and also Coxiella burnetii and fungi other than Candida. What is the risk factor for suffering endocarditis? Are going to be structural and environment. What I mean with structural, when the patient has already a history of infected endocarditis. Why? Because the valve was already damaged. Also, when there is any kind of valvular or congenital heart disease, what I mean with the environment, I mean like the bacteria has gained access to the bloodstream, such as when the patient uses intravenous drugs, when there is any kind of a cardiac device or intravenous catheter, such as central line, when the patient is immunosuppressed, when there is any kind of recent dental or surgical procedure. When we consider prophylaxis, we're going to consider prophylaxis in two, when the patient meets two title criteria. When there is a highest risk of infected endocarditis, the patient has, for example, prostatic cardiac valve or any kind of material inside of the heart. When the patient already has a history of infected endocarditis, when there is any kind of congenital heart disease, or when the patient has received a cardio transplant, but that cardio transplant has a valvulopathy, where when there is any kind of really kind of big procedure such as dental work, a respiratory tract procedure, when only when incisions or biopsy is performed. For example, the patient is going for bronchoscopy, but there is no biopsy. We don't need to give like prophylaxis for prophylaxis in that case. And when there is a skin of soft tissue procedure, or when there is any kind of cardiac surgery with prosthetic material. So no prophylaxis. This is important to talk about. No prophylaxis. We're not gonna give prophylaxis when there is any kind of GI procedure or urologic procedure. But the patient, for example, in colonoscopy or endoscopy, we don't need to give prophylaxis. When we consider to give prophylaxis when there is any kind of those procedures, when the patient has a highest risk cardiac condition, for example, the patient previously has a infected endocarditis, but there is ongoing GI or GU, such as in cytoscopy infection. For example, the patient going for endoscopy and there is an infection going on in the GI tract, but also the patient has a risk factor for infecting endocarditis, we are going to consider give like prophylaxis, specifically for enterococci. What is the clinical scenario of the patient who has infected endocarditis? The patient are going to be having fever 90% of the cases. Fever associated with the chills, arthritis, malaise, all of that that you can add it. Also, the patient are going to have like a new cardiac murmur. It's not enough like the patient already have a murmur and have increase of that murmur. It's not enough. It has to be a new cardiac murmur. Also, different kinds of signs such as rust spots that we are gonna find the retina, Osler nodes that we are gonna specifically find in the pad of the fingers, and those are quite painful. Also, we are gonna notice in the physical exam a splinter hemorrhage that are gonna be found in the nail. Also, Geneway lesions. Those are found in the palm, but those are not painful as a Osler nodes. And also any kind of complication due to septic embolization. What does that mean with that? For example, the patient has a glomerulonephritis or the patient has a pulmonary embolism when the endocarditis affect the right side. So in the right side, those microemboli travel to the lung. Also, the patient has a stroke or even like a vertebral osteomyelitis could be a complication of infected endocarditis, such as, for example, the patient is having signs symptoms of infected endocarditis and tells you, "Oh, my back hurts." So that gives you a hint, or could be like a osteomyelitis or the colon or the vertebral column. So we have to like do a workup for that. What we're gonna have in the lab? In the lab, we're gonna have elevated inflammatory markers. The patient are gonna have anemia and RF positive, false positive. I will say rheumatic fever. Also, a syphilis test could be found could be found even though it's false positive. That and also low levels of complement. Why? Because those emboli in the endocarditis are going to be immune complexes and are going to lower the complement levels in blood. How we diagnose a infected endocarditis? We're going to diagnose with two criteria. In two criteria, we have major criteria and minor criteria. Major criteria is essentially when we are going to have positive uh, blood cultures. Positive blood cultures are going to be an evidence of endocardial involvement. Positive blood cultures we have when there is going to be found positive blood culture with typical organisms such as Staphylococcus aureus or virions or By the way, there is another kind of organisms called Streptococcus galolepticus that or bovis also called. That is gonna be a more common in patients, or is gonna be a suspicion of a colon cancer. Also, a Hazer group could be considered like a common organism for consider these major criteria. So also when we are gonna have like a major criteria is when there is evidence of endocardial involvement, such as when we do an echocardiogram and we found vegetations or any kind of abscess there, and when there is a new when the patient has a prostatic valve and that prostatic valve has any kind of a a any kind of defect there or any kind of a rupture there, we're gonna suspect infected endocarditis. And also there is a new valvular regurgitation. For example, the patient we do like a echocardiogram and there is kind of a new regurgitation that we saw that we didn't see previously, we're gonna suspect infected endocarditis. Minor criteria. What is the minor criteria? Especially fever. When there is any kind of vascular phenomena. We already talked about vascular phenomena. It could be like a arterial emboli, also like a pulmonary emboli that could cause infarction, also like a conjunctival hemorrhage, also like any kind of a immunologic phenomena such as we already talked about glomerulonephritis, rat spots, Osler's nodes, or positive, even positive rheumatoid factor. So, and any kind of microbiologic evidence such as positive blood culture, but those positive blood cultures are not caused by the common organisms. So when we find majors and minor criteria, that modified those criteria are important because give us what could be the probability of having infected endocarditis. And it's gonna give us three types: definite, possible, or rejected. Rejected meaning like, oh, there's no way that could be like infected endocarditis. Possible meaning like could be, and definite, definitely you have to treat it. So when we are gonna have definite, we're gonna have definite when we need like two major criteria. Doesn't matter if the patient doesn't have fever or doesn't present with the clinical symptoms. When we have positive blood cultures or evidence of endocardial involvement, we can diagnose with the infected endocarditis and we should treat it. Also, when the patient only have one major criteria, for example, the patient doesn't have a positive blood cultures because could be negative because for the Hazer group, but has evidence of endocardial involvement plus three minor criteria. For example, the patient has fever, we found like a any kind of hemorrhage, or we have any kind of a glomerulonephritis, even we are gonna have a we can diagnose with infected endocarditis. And finally, when we have five minor criteria, for example, the patient that you see in the hospital has fever, so that is a one minor. You examine the palms of the hands and you see a kind of hemorrhage there, so that is second. You do like a blood test and rheumatoid factor is going to be positive. You have three. And you see any kind, you do like an echocardiogram and you see any a small vegetation there. So there you go. You have a definite diagnosis for infected endocarditis. So the next topic and the last one is the management. What is the management? It's two types: antibiotics and removal. What I mean with removal of any kind of a foreign body that is in the body, such as if the patient has a central line, you have to remove that. If the patient has a prostatic valve, you have to remove it and replace it. So, what is the management? Antibiotics, especially is empiric, after you take the blood cultures, not before, because you take the blood culture after you give empiric antibiotics, those blood culture are going to be falsely negative. So, in the left side, the duration are going to be 6 weeks. As you can see here, counted from the first day of negative blood culture, meaning first, you take the blood culture, you give antibiotics, then you have to take like 48 to 72 hours after. After you have negative blood cultures, you start counting 6 weeks. If the most common left in the left side of the heart that is going to cause infected endocarditis is going to be Staphylococcus aureus. For this reason, if we suspect that the Staphylococcus aureus is not methicillin resistant, we're going to use oxacillin. If the patient is allergic to penicillin, we can use the first generation cefazolin. But the patient comes from a nursing home or has been hospitalized for a long time, and we do a MRSA swab, and the MRSA swab came back positive, we have to use vancomycin. If the patient, for any reason, cannot use vancomycin, or the organism is resistant to vancomycin, we could use daptomycin. And gentamicin, in some guidelines, we can use gentamicins to potentiate the vancomycin or daptomycin. When we consider surgery, when there is any kind of heart block or paravalvular access, how we diagnose that heart block? Because the patient has to be admitted in telemetry, and we're gonna here in the telemetry unit, we are gonna know if the patient has any kind of a new abnormality of the electrical, the, any kind of arrhythmia. In the right side of the heart, that is only 10%. Remember that if the patient we suspect could be like a staphylococcus, but is not resistant to methicillin. For example, the patient is a drug abuser. We're gonna suspect more likely in the right side of the heart. The patient present with also with pulmonary symptoms, we suspect with the right side of the heart. And again, the time here is only gonna be 2 weeks. We are gonna use the same antibiotics. If those antibiotics doesn't work, we can use vancomycin for 4 weeks. And if that doesn't work, we can use the daptomycin. If when is a right-sided infected endocarditis complicated, when there is a left side involvement, when there is complications such as heart block or there is access, or when there is a metastatic infection outside of the lung. Remember, if you have in the right side, it's more likely that you are going to have emboli to the lung. When there is renal failure or when there is no response within 40 to 72 hours. Um, when we suspect MRSA, what is MRSA is treated, we're gonna treat it on the left side. We're gonna use vancomycin or daptomycin for 6 weeks. And when we consider surgery, when we do like an echocardiography, and the echocardiography is show us more than 20 millimeters of vegetation, the measurement when there is a recurrent septic pulmonary emboli. What is that? Because what does that tell us? That the axis is too big to treat it with antibiotics. As whatever axis, we have to drain it. Also, we consider surgery when the organism is highly resistant and when there is a persistent bacteremia. And this is Havana's Hayes group, culture negative. We have culture negative, we suspect or infecting endocarditis. For example, we have like a major criteria and 3 minor criteria. We're gonna treat with ceftriaxone, and penicillin usually is avoided here, but we can use as well and ciprofloxacin. And the Hayes group, here we see what kind of organisms are those. Thank you for watching. If you have any questions, let me know right below, and I will be I will be answering your questions. So I will be back with another topic, and I hope that you enjoy this lecture for today. Bye bye.